Welcome, everybody. I'm Diane Lipscombe, and I'm here with Chris Moore and Karen Furie, and I'll introduce them in a second. And this is, I think, our 12th or 13th Carney Conversations, and the topic today is COVID-19 and the brain. So Karen Furie, I think I see Karen right now. Can we see? Oh yes, hi Karen. Thanks for joining us.
My pleasure.
I'm going to do a quick. I'm going to do a quick introduction, and just to kind of highlight your Brown class of '87 grad, Karen.
That's correct.
And in the true Brown tradition, you were a pre-med and also an English and American literature concentrator. And then you continued and did your MD, at Brown University School of Medicine, Masters in Public Health at the Harvard School of Public Health, interned at Miriam Hospital here in Providence, and neurology resident in the cerebrovascular disease at Rhode Island Hospital, and then you joined the faculty at the Mass General Hospital in the stroke service unit. But it looks like, you know, everybody here at Brown was like, we got to get Karen back. And much to all of our delight, you returned, you were directing the MGH stroke service, I think, and then we moved you back to Brown. And so you came back here in 2012 to be the chair of neurology at the Alpert Medical School at Brown University. You know, I think that it's been remarkable, you know, what's been achieved in the neurology since you came in as chief. And I think many of us actually know how incredible the department is, but you know, I think I've been struck by the incredible talents in your comprehensive stroke center and the impact that they've all had on, you know, the population of Rhode Island. There was the team was highlighted in a Wall Street Journal article. I think it's just tremendous, like that having this incredible facility here and saving so many lives, and actually preventing real serious consequences of major strokes. So how many, you know, I should know these numbers, but how many patients do you have coming in, you know, kind of on a annual basis into the stroke care center?
So we have about 1,200 ischemic stroke patients.
Wow.
And the neurointerventional team does close to 300 of the mechanical thrombectomy procedures per year. So we're a very busy stroke center, even by national standards. And part of that is the fact that we're the only comprehensive stroke center for this region, which not only includes the 1 million lives in Rhode Island, but also part of southeastern Massachusetts.
Right, right. And then there's this kind of critical time window, right, between the onset of a stroke and then the time to treatment.
Right. Right. So the concept is that as the blood flow, as the brain is deprived of blood flow, neurons begin to die. And the more rapidly you can restore the blood flow, the more brain will be preserved and function will be preserved. So absolutely, the goal in acute stroke is to work as quickly as possible. And to that end, in Rhode Island, we've really empowered EMS to make decisions in the field so that they can bypass hospitals that can't deliver mechanical thrombectomy, and they can bring them directly to our doors so that we don't waste any time with transportation or transfers. We try to get them in, get them evaluated as quickly as possible. It's called a code stroke. You hear it being broadcast over the loudspeaker system. And then the team descends and tries to get restoration of blood flow as quickly as possible.
Oh, it's amazing. And there's a number of videos. I encourage everybody who's listening to this to go take a look at those videos in the clot removal procedure. It's extraordinary. I mean, completely extraordinary.
No, it's been a tremendous game changer in our field. When I trained in stroke, prior to having either the clot busting drug, TPA, or the mechanical thrombectomy procedure, we would routinely see people come in, devastated, unable to speak or move their dominant side, and we had nothing to offer them. And now the same patient could get restoration of blood flow within hours and leave the hospital the next day. We've described it, it's been described as a Lazarus effect, but for those of us who've been doing this for decades, it's truly astounding and incredibly rewarding.
Yeah, it's amazing. And, I think Chris and I might come back to, thinking about reduced blood flow impact of COVID-19, and we're going to get into this shortly. But before that, I should really take the opportunity to just chat to you quickly about, this announcement that came out over the local news today in Rhode Island about this merger between Lifespan, or an agreement to merge between Lifespan and Care New England, and also an accompanying agreement with Brown University to create kind of a single healthcare system in the state. So let us hear a little bit about your impression of that. This has been a lot of negotiations.
No, it's really fantastic. It's been a long time in coming. Several people on the call may be aware that this has been attempted, I think, 5 times in the past, and it's never actually come to fruition. And as a result, for a relatively small state, we have competing healthcare systems and overlap of services, which is inefficient. We're fortunate that in many things, like stroke and like our response to COVID-19, there was coordination of care on a statewide level, which was fantastic. And I think that really, especially the COVID cooperation, really inspired people to try this again. It means that we will be able to coordinate care in a logical, rational, cost-effective way. And it will really improve the delivery of care to people in Rhode Island. So I'm very excited about this. When we think about especially delivery of neurological services, it's been somewhat uneven, and this is an opportunity to try and get to various communities and ensure that all of the institutions in the state can deliver the same quality of neurological care.
Yeah, great. I mean, I agree. It's really exciting. And I think it's going to make a huge difference also in terms of kind of basic research, being able to connect to the clinical departments, and lots of.
And with Brown really at the hub of this too, it's important that we haven't had a truly integrated academic healthcare system to date. And this is truly a big step forward in making that a reality. So I think everyone's very happy.
Great. Well, thanks for that. So I just want to remind everybody who's listening, thank you for joining us. You can actually post any questions you have in the Q&A, and then Chris Moore, who I failed to properly introduce. Chris, my apologies. Chris is the Associate Director of the Carney Institute for Brain Science, and he and I have been doing this these interviews with our colleagues and people who are like, we just have to talk to Karen Furie. And so it's been hugely fun for us. I want to say a quick hi, Chris. So we'll have some questions back and forth, and Chris and I are going to be looking at the Q&A that's going to be coming in, and we'll be posing the questions that you post. So please do that for us. So Karen, we all know COVID-19 is, we think of it primarily a respiratory disease, and we're still in the thick of it. But we're here to talk about the growing evidence, accumulating strong evidence of many cases. In some cases, COVID-19 can lead to kind of neurological problems, acute, and then potentially quite chronic. And we don't know how chronic yet because we're kind of in the thick of it. But I thought maybe it would be, I certainly want to know if you, Karen, can kind of take us back a little bit to, what was your world like a year ago, and then how did that change? And is there a moment like that you could tell us about where you just realized, oh, this is different? like this is crazy.
Oh,
Something
yeah,
is happening here.
absolutely. And I've never seen anything like this in my career, certainly. I think few people have. It's curious because just about 1 year ago, I was coming back from the International Stroke Conference, which was in Los Angeles. And at that time, our colleagues from Asia were already unable to travel to the meeting because of the travel ban. But it really hadn't started to really get on people's radar in the United States. And things escalated very quickly after that. So that was February 2020. And soon after the first cases in the US were identified, the hospital really launched a major initiative to begin providing adequate protection to the employees, training us in how to doff and don our various protective gear, educating everyone very quickly about what was becoming known about COVID coming out of Asia and then Europe. And then it almost had a surreal feel to it, where units were being turned into what were called warm units, where there would be signage, warning everyone that was a COVID unit and that you had to put on the appropriate garb and take appropriate precautions before entering it. And we had to convert our outpatient service to almost exclusively teleneurology because of concerns about spreading COVID to patients, and conversely, having patients come in and become infected within the healthcare system. And it was bizarre, and everything moved incredibly quickly. And week to week, we were learning more information, and so policy was changing. I began a weekly update to all of the faculty about what was happening statewide and within our own department. There were daily conference calls to share information, and all of our journals and professional organizations began to expedite publication and notification about COVID and its various manifestations. So as I said, I've never experienced anything quite like that. And our whole system for delivering healthcare changed radically over the course of weeks.
Yeah, it is extraordinary how, certainly I had been fixated on, certain aspects, but you covered a number of different points here, which are all connected. One, just how you all had to pull together and just completely change the way in which you were operating. Not just for the patients coming in, but for patients who would have normally been coming in, and now suddenly you have to create a different service for them because they're still in need of treatment. The importance of the global community, the incredible transfer of knowledge and information and know-how and techniques, across the globe, which I think is something that we all have to really remember. And then you mentioned this, how we share information, and I think we have this standard way. It's like you do a trial, or you have a procedure, you get your data, you analyze it, you write it up, you send it to a journal, the journal reviews it, and that timeline just completely collapsed. It had to collapse, right? And so that whole system of disseminating information just completely changed as well.
But people really rose to the occasion. The number of submissions to our journals actually increased as people, started to initially submit case reports or just brief reports about how change in practice could help protect the healthcare teams, and to share that information in real time. And all of that grew. So, went from case reports to case series, and then to multi-institutional reports. But it was really quite amazing to see how people just sort of shifted gear, and even were able to change their research focus a bit, because normal research was pretty much shut down during this period. And the institutions were only allowing COVID-related research, but people sort of shifted so that they could help address important questions about COVID.
Yeah, and also the public kind of responded to that, and I think that there was this enablement, in the the philanthropic kind of community are like, yeah, now is the time, like we can't wait here. And so I think that has been really tremendous to see. I think we're going to come back to that probably, Chris. The one thing I just wanted to jump in here to lay a little bit of groundwork is to ask you in a little bit more detail about, the patients that you are treating, your COVID-19 patients that you've been treating for this past year, continue to treat, and maybe give us a little kind of framework around what are the symptoms, what are you seeing, how different are they from what you normally see?
Sure.
And then, what are the pre-existing conditions that you're seeing that allows you to make kind of predictions about who's going to have a more chronic or more severe impact?
Yep, sure.
Yeah.
So I'll just take a step back to say that, this is primarily a pulmonary infection. And the reason that people become severely ill or actually die of this is generally because of the pulmonary involvement. However, people still have underlying conditions, stroke, heart disease, and they can become infected with COVID and come into the hospital perhaps with symptoms of a stroke or TIA and then be found to be COVID positive, which is the more common route to how neurologists got involved in the case. Very early on, people were reporting that there were neurological complications of COVID. And I have to say, when they first started coming out, it didn't seem that impressive. They were what you'd expect when you become acutely ill, even with influenza. You become fatigued, you're confused, you have a fever, you have a headache. And so at first it all seemed very general, delirium in the elderly. It didn't seem like there was anything very specific to COVID. And then people began reporting that one of the early symptoms of the infection was loss or reduction in smell. Well, that's a very focal neurological symptom. And then there were other publications that started coming out. And this really was reflective of a systemic response to COVID, where in some patients, the COVID caused an acute inflammatory response that affected the entire body and could trigger clotting in the body as well. And so we began to see reports of neurological symptoms that were the result of clots in veins or clots in arteries in the brain. And again, this seemed to be a more specific problem related to the infection and not just the generic encephalopathy and delirium and headache that you'd expect to see with just routine viruses. And the loss of smell and taste remains a very interesting element, and it's become one of the diagnostic criteria for COVID infection. And it led to a lot of speculation about whether that was the way that COVID might actually be introduced into the nervous system.
A few thousand questions, Karen, so I hope that's okay.
I doubt that.
No, it's just so, first of all, we appreciate it so much that you're coming here to, this actually happened when we were talking with the people that were setting up the Zoom call today. I think everyone has stories of someone they know or their own experience with COVID that feels neurological or psychiatric in its manifestation, right? And trying to get your arms around, or especially as a person who's not a medical doctor, like trying to understand which of those are idiosyncratic and just happen, or which might be a consequence is really confusing.
It is. It's very difficult to sort out. And it's been an area of controversy, whether in fact it's active infection in the nervous system that causes these things, or perhaps just the body's immune response and the secondary effects of that systemic inflammatory and hypercoagulable state. So as of today, I don't think there's an absolute answer to this. There is some evidence, and this is really fascinating to me because I'm a stroke person, that COVID causes some type of acute inflammation in endothelial cells that line blood vessels throughout the body, but in the brain as well. And that perhaps some of the primary neurological manifestations of COVID may be related to endothelial dysfunction in the setting of COVID. And that can cause what we describe as white matter disease or a leukoencephalopathy. And there've again been very characteristic imaging findings of tiny, tiny hemorrhages that you can only see on an MRI scan using special images that may reflect this endothelial damage. So again, I don't have hard answers to this, but it appears that the blood vessels, and especially the microcirculation, may be very much involved in the course of this disease. And there's evidence from other organs like kidneys that fail as part of COVID as well, to suggest that that might be the case. And so there may be some individuals who are more susceptible, and this is getting back to Diane's question. People with features of metabolic syndrome, which are obesity, hypertension, dyslipidemia, and insulin resistance. Folks that typically go on to develop heart disease and stroke may be a particularly vulnerable population. So if you think about it, they may already have some degree of underlying vascular disease and some degree of systemic inflammation, which is part of vascular disease. And so when they then contract COVID, it may trigger an even more robust response because their basal levels may already be quite elevated, and they may already have some disease in their cerebrovascular system. So again, this is largely speculation, but certainly the data that have been reported observationally do support that as a possible mechanism.
Yeah, it feels like, from what you're saying, there's a whole nother layer to the pre-existing conditions and risk, right? This is the neurological version of what people are experiencing for the overall sickness.
And there is an existing literature to suggest that other infections can predispose to stroke. But I think the immune response is much greater with COVID. And again, the number of people infected acutely was much higher with COVID than you would see with other even common infections like flu. So it probably was just a perfect storm for some individuals to go down a very bad path and to develop this very fulminant pulmonary problem, but also problems with other organs, perhaps related to this vascular phenomenon.
Geek out on the basic science side, but endothelial cells are fabulous cells. I mean, there was an old report that they formed the saran wrap of the brain because they formed the blood-brain barrier, that they were just this kind of passive sort of wall or something. And we're doing some of the work in my lab, but there's lots of really neat work showing that they really actively can signal to one another, and they form these fabulous networks in the brain. They're really interesting cell types. So if they're, as you're saying, that they're targeted, it could have tons of implications for brain function. It's really a critical cell type. I mean, is there a connection between the blood-brain? I mean, they form the blood-brain barrier mostly. Like, the blood-brain barrier is a complicated thing that's more than that. But is there a blood-brain barrier connection, do you think, between what's going on?
People have speculated that the virus could directly infect cells through the, oh my goodness, there's a receptor I'm blanking on for a minute, but it could directly infect cells, or it could enter the nervous system through paracellular pathways. And then there's also an immune component to the blood-brain barrier. And if this is the Trojan horse model, and so if the macrophages engulf the virus and that gets them across the barrier, and then they can then replicate and take over now that they're within the CNS, that might be another way of actually penetrating the barrier. So all of these are very interesting. And there are some reports that they've been able to demonstrate viral RNA in the nervous system. But those have mainly been through CSF analyses, and those can be contaminated by blood. So I'm not sure if that's going to end up being the primary mechanism of involvement. But as you point out, it doesn't have to actually get into the brain if it's affecting the endothelial cells. There might be enough communication between endothelial cells and glia and neurons to affect the nervous system, even if it doesn't penetrate it.
right?
It was,
It's
as
just,
you were talking, sorry, I was just
yeah,
gonna
go
say
ahead. No,
the,
go ahead, Dan.
call out in the Q&A, which I thought was actually really at the almost the moment that you were starting talking about the blood-brain barrier, mentioning the late Ed Stoper, and this is a comment from Walter Abboud saying that Ed used to refer to the choroid plexus as the kidney of the brain. I thought it was actually really great. Thank you, Walter. Yeah, I think I might let Chris nerd out a little bit more on this, but one of the, I'm actually really interested in, you talked a little bit about the ways in which your understanding of this huge immune response being quite different. Is there a way that you could kind of summarize, the treatment that you were doing in the clinic, in the initial as patients started to come in the initial phase of the pandemic, and then how are you really thinking about treatment now, and how has that changed?
So, there were no proven treatments when the whole pandemic started. Remdesivir came out and started being used under a research protocol initially, and then became part of the routine protocol. And because inflammation was obviously part of this and could be demonstrated through biomarkers in the blood, steroids, immune suppression with steroids also became part of a more standardized approach to preventing this fulminant picture. Because of the hypercoagulable states, people also began using anticoagulation and using blood biomarkers such as D-dimer in order to identify patients likely to go on and develop thrombotic events. And these are very dramatic. Typically for stroke, for instance, you have a clot in a vessel. The clot can come from the heart, or it can form de novo in a cerebrovascular structure. But what we see with COVID is clotting throughout the body, clotting in the arteries of the limbs. You've probably heard stories about people in the news who had to have amputations because they lost blood supply to their limbs. When they undergo procedures like mechanical thrombectomy, while they're retracting the clot, new clot is forming on the catheter. It's just a fulminant active process that's really not like anything we typically see. And so there's really just been an attempt to try and be as aggressive as possible to take the therapeutics that we know about that either suppress inflammation or inhibit clot formation, and just try anything you can to try and restore hemostasis, and then to get it out to your colleagues through blogs, through list servers, through publications, so that other people can learn from that experience. But it's very much been a figure it out in real-time situation.
If I could ask a quick question after that, Karen. So one thing I've heard about are COVID fingers and COVID toes.
Right. So those
is that related?
Yeah, it's the modeling that you see with ischemia in the distal extremities. So it's, again, part of this whole process. It all does hang together biologically. The question is just how to identify individuals at risk and intervene sooner rather than later. And we certainly learned a lot between the first and second peaks of this pandemic. And the whole approach was very different in the fall, because we had the experience from the spring. And this gets back to something that Diane mentioned earlier. When the first cases started coming in, the public's health message was, don't come to the hospital, stay at home. We don't want you to come in and get infected. And we're seeing this high volume of cases, so we don't want to clog up the healthcare system with patients coming in with minor problems. And unfortunately, the way the public interpreted that, they were staying home with pretty much all their symptoms. And so we saw a dramatic drop off in people coming in with strokes and heart attacks. And we were really concerned that people were, by virtue of staying home, they weren't eligible to get thrombolysis. They weren't eligible for mechanical thrombectomy. And so when we anticipated that there was going to be another peak in the late fall and winter of this year, we really changed the messaging around that to try to get people to remember that they shouldn't stay at home if they're having stroke-like symptoms or chest pain, and that they did have to come in and get routine health maintenance, because all of those other health problems didn't melt away just because of COVID. So there really was a big change in approach. The second time around, we didn't want people to neglect other symptoms, and the healthcare system figured out ways to adapt to the higher volume and the changes in types of patients.
As you were talking, Karen, I had running through my mind, this. So the acute disorder that you're treating is stroke. The origins, of course, are quite different across multiple different forms of stroke. And I'm wondering, as you were talking, whether is it in the case of COVID-19, in many cases, this is just extreme, right? You have this massive immune response. And so you're dealing with a kind of an extreme condition. But is it possible that this will tell you something about potentially ways to stratify in terms of treating what you'd consider in the normal range of your stroke patients, and perhaps there's a population in there that don't have such a massive immune response, but still have a component to it, and that potentially, this extreme condition is really going to impact the way in which you treat stroke patients or think about the origin of stroke in the population.
I absolutely think that we're going to learn more from research around COVID that will impact our thoughts about immune modulation and the interaction between the inflammatory system and the coagulation system. So this is an opportunity, I think, to view this much more broadly. And the questions about blood-brain barrier integrity and how systemic infection affects the central nervous system. Again, I think this is going to trigger a whole resurgence of interest in this area that will have implications for lots of other diseases. I mean, neurodegenerative disease, perhaps there's an interaction there. Perhaps some of the long haul COVID symptoms may be some type of secondary sequela to this acute inflammatory event. I hope not, but people are already reporting symptoms and findings consistent with an immune response similar to what you see, the demyelinating effects with multiple sclerosis and Guillain-Barré syndrome as a consequence of COVID. So understanding that better and understanding the relationship between systemic disease and how the brain responds to it is critically important. And if we learn new ways of being able to detect risk so that we can intervene earlier, again, I think it's going to move this whole field forward considerably. From a public health perspective, it also tells us that pretty much we knew that obesity, sedentary lifestyle, insulin resistance, high blood pressure, those things are all bad. And this is yet another reason to aggressively try and manage risk factors in the community. People, especially young people, tend to think about heart disease and stroke as being a disease of the elderly and may not be concerned about those risk factors. But COVID has shown that if you have those risk factors, even a young person can be devastated by something like this. So definitely a wake-up call for public health measures.
How would you, if you think about what you just said there, I think it was incredibly important. Do you think that we train, maybe take both sides, do you think that we are training, or do you think that neurology training paths are appropriately, ready to respond to, this type of rethinking, thinking much more not about the end organ that is being affected, but much more about all the multiple possible origins involving other systems. And so how do you think about that in terms of the training you had medical school. That'd be one. What you might rethink in terms of training residents, but also what do you need on the basic science side? You know, better diagnoses, better biomarkers. Like, what's missing in your ability to be able to really dive into this really important way of thinking about disease?
Over the course of my career, I have seen a transition from a very siloed approach that was organ system based to a more holistic view of how problems like inflammation affect multiple organs. And I've seen much more collaborative research with neurology and hematology, cardiology. There are whole new fields that have come up. Neuroinflammation didn't used to be a separate subspecialty when I was training, and now it has its own training course. I believe that the thinking about neurodegenerative disease and its overlap with cerebrovascular disease has been completely transformed. There actually used to be a clear distinction between whether you had vascular dementia or Alzheimer's disease. And now we recognize that the two overlap significantly, and that modification of conventional vascular risk factors is important in both the development and progression of Alzheimer's. So I think people are appreciating that you have to break down those constructs that it's one disease or another, and instead look at pathophysiology and how it can affect the disease at various stages. So I think the field is moving in the right direction. How that's going to impact training, though, is a great question, because we're learning so much in the various fields. How does one keep up with it and share that information? And I don't have a good answer for that. I think more connectivity is probably the answer. And you have to kind of get out of your own world a little bit to appreciate that folks in completely other disciplines may be learning things that can impact your understanding of brain function, immune function, cerebrovascular system. So it is an exciting time.
Yeah, and you know, Chris I think is going to jump in a second, because we have these discussions a lot. And you know, we talk about neuroimmunology now or neuroinflammation, but it's always like a pairwise thing, because it's really hard to have three different systems in one name.
Right.
But that shouldn't be the limitation, right? It shouldn't be because it's easier to say neuro something. Like that I think that's the beginning of thinking very much how you study systems of systems of systems on systems,
right.
and what kind of approach and what kind of methodology is going to be needed to do that. And I don't think that we have actually on, you know, in the research side really come to grips with that. I think it's certainly, we're aware of it, but one tends to fall into kind of the traditional way of training and methodological approaches, and like what's the basic information you need to know about, you know, neurons and firing of neurons. And you know, I think there's a long way to go, but if you have
I don't mean to sound too self-congratulatory, but one of the things that the Carney Institute provides is that forum. I remember Chris and I met within the last year to talk about ideas around clinical translational projects involving blood-brain barrier integrity. And you know, it's so exciting to get out of my world and the hospital and come over and just think outside the box, almost in a science fiction way about these things, because currently we don't manipulate the blood-brain barrier not to deliver medication, not to modify disease progression significantly. And so to even start to think about that and have a discussion about that is a lot of fun, and may lead to great things in the future.
I mean, here's hoping, right? but that is one of, you know, as I don't think it's self-congratulatory to say that Brown's just awesome that way, right? There really is this ability to walk across town or across the hall and people have their door open.
Yeah,
and
absolutely.
until you've worked other places, you don't realize how, it just seems, of course, but until you've worked other places, you don't realize how wonderful that is to community. So as tantalizing as it is to want to begin talking about all brain systems together, I really want to talk about at least a component of the long haul too here, because some of the reports on things like depression are amazing, right? They're just the number of people that report that did not previously report depression. They're reporting anxiety. Some people say it's as high as 40% of all adults. So that's the other, COVID has infected our species, right?
Oh, absolutely.
And so there's, even if you haven't caught it per se, you've caught the pandemic, right? And depression, anxiety. How is that showing up in your clinical practice? How does it relate to?
It's certainly connected to a lot of the reason people are presenting with symptoms that are vague, things like brain fog, problems with attention, concentration, a lot of overlap with depressive symptomatology. But if you think about it, there are people who still work from home. There's little or no opportunity for socialization. They may be homeschooling children while juggling their job responsibilities. It's hard. You don't go to restaurants, you don't go to movies or theater or concerts. And you're hearing about friends, family members who are sick, who may be dying. And then there's all the news, and I won't even get into that, but of the past year, I think it has a profound emotional effect on people. And, certainly there may be lingering, organic effects from the virus. So that definitely is possible. And we may learn more about some of the biological changes or the biomarkers that we can use to identify some of the consequences of COVID infection. But I completely believe that that addressing depressive symptomatology and anxiety will also help with quality of life. It may all be reactive and appropriate, but it's still an issue. People have to overcome it in order to function. And at some point, we're going to have to get back to regular life again. So it shouldn't be dismissed, and it should be part of what clinicians are talking to their patients about.
And anybody who works with anyone else should be talking or figuring out ways to, because it's such a hard time right now in that regard. I mean,
absolutely. Everyone's routines are thrown off. We're not outside, especially this time of year, not doing the usual rituals that bring people a lot of joy. So Zoom is wonderful, but it doesn't replace everything. So anyway, I see a light at the end of the tunnel. I already at least hear the fact that the vaccinations are available has changed perceptions dramatically. I can't tell you how different it is to have that confidence and to know that eventually we're all going to be protected. It's a big change from the way people were feeling last spring when we had really little to hope for. So.
I just wanted to try and capture a couple of the questions, maybe just in one bigger, comment from you. There's a few people who, are referring to relatives who've had COVID-19, and I think this is a huge challenge, right? It's like you're not going to know the underlying symptoms, and so it's very difficult to say, is there cause and effect? And it's very hard on people, who are looking for wanting a kind of a clear diagnosis, but the characteristics of this disease make it really quite challenging. But there was one kind of maybe an overarching question where it's like, individuals who've had no symptoms of for example, cognitive decline, and suddenly, that they see family members experiencing, a form of cognitive decline. It's just kind of out of the blue, very rapid onset. And it does, not to make any commentary on those particular cases, but that does, there are a number of neurological disorders, right, that can come on quite acutely and have a quite sudden impact on cognitive ability. And
that's right.
Yeah.
Now, this is why I love neurology, because it's always a puzzle. So the question is it COVID that has now cause some kind of rapid progression of neurodegenerative disease or demyelinating disease or some other process in the brain? Or are the cognitive effects due to depression, which is very possible? People who are depressed have low energy, poor memory, a lot of overlap there with symptoms of dementia. Again, if you're not going outside and you're not eating your regular food, could you be developing vitamin D deficiency, vitamin B12 deficiency, thiamine deficiency? Could you even have a new medical problem like thyroid dysfunction, that because you're not going in for your routine health checks is not being diagnosed? So it really requires a very comprehensive evaluation. And part of that is talking through what the symptoms are, but it may require coming in and being evaluated and getting some blood tests done. That fear of interacting with the healthcare system has to be overcome because you don't want to miss something that is reversible and rapidly progressive. And as we pointed out, you can have problems that are not COVID related, and if you're not getting on top of them, they can still lead to significant disability in the long term. So those things shouldn't be neglected. The first stop is probably with a primary care physician. Not everybody needs an MRI scan of the brain and a spinal tap, but the primary healthcare provider should at least do an initial assessment and try and sort through when it's appropriate to refer to a specialist and do some additional imaging and perhaps blood tests.
One thing that I want to at least do a dashed line to is in thinking about some of the really profound depression effects and the inherently sedentary condition we find ourselves in, when exercise is often one of the only hopes for, but it can have wonderful effects on things like depression and brain fog. There seems to be a really neat, sticking with our theme of those wonderful endothelial cells and their engagement, but there's a deep connection here between something like the ability to exercise and the impact that can have, and the neurological, it's obviously a lot more complex than any one factor, right?
That's right. And even the coagulation system, there's a part of the coagulation system is to form clots. And then on the other side, your body is actively dissolving clots just normally. Exercise helps stimulate the dissolving clot side of that equation. So if you're not getting out and exercising, your hemostatic system is not optimally balanced. And so yes, exercise and eating well and being compliant with medications are really important, because you don't feel your endothelial cells malfunctioning. There's no specific symptom for that. And yet if you're metabolically deranged, that is going to be happening silently in the background. And whether it affects you next week or next year, it's still not a positive effect on your brain.
Yeah, absolutely. Maybe we're feeling it as brain fog partly. That's some of that cognitive symptomology could go with that.
I like metabolically deranged. It's a good term.
It's definitely a slogan or something. Yeah.
It may be enough to get me out to exercise in the middle of grant writing.
Get on the treadmill.
Metabolically deranged.
Right. Yeah. It just feels like you really should do something about it. There's again a couple of other questions, but I'm trying to weave these in. And I wanted to ask you now to, we're kind of thinking forward, and to ask you about whether, we talked about different ways in which you're treating patients now, the need for more diagnostics. There's actually a question here about, is it possible that there'll be a panoply of kind of inflammatory biomarkers that will become a standard form of care? Like as soon as you get patients in, you do a whole set of analyses to ask, what are the different cytokines and interleukins that are present, and that will inform treatment. So that's kind of one piece.
Yeah.
And then the other piece, which is kind of different, but still in the frame of like, how are things going to be different? How do you imagine even just, these protocols for reducing the spread of communicable diseases, they seem just really quite sensible in a hospital. And, and so are these the kind of thing, what kind of things and what kind of procedures that have now been incorporated do you think will stay, and be with us for good reason? Not because we're fearful, and there's no reason to be fearful, but really because this is the thing that we should be doing. So I guess the first thing is, biomarkers, standard care, and then, changes in protocols and the way in which we go into the clinic.
I do think it's possible that we'll be more specific in our testing in the future. There have already been reports that drugs that inhibit IL-6, IL-8, IL-10 may be beneficial. And those are not at all part of the routine assessment, the number, the profile that you get when you come into the hospital, whereas things like D-dimer and ferritin are clinically relevant and available in our clinical laboratories. And so people began identifying them as biomarkers of infection and of a more severe course. But certainly one of the things that may come out of this is that we have to refine which blood tests we actually look for and apply in the acute setting. So I do think that may change in the future. I think hand washing, hand hygiene is really important. So I can't imagine that anyone would have that go away. And the masking is really interesting because it's been part of some cultures, but certainly never very prevalent in the United States. And yet it's cut down significantly on transmission of flu this year as well. And so I wonder if moving forward, we will routinely during flu season and when there's notification that there's an outbreak, we'll all go back to using masks, especially when you're sitting on an airplane or in a closed space where people are coughing and sneezing or all around you. So it seems unlikely we'll go back to our previous indifferent state. We're all going to be much more conscious of how close people are, and again, whether the people next to you seem ill, and our use of sanitizers and whatnot, it will probably continue long term. From a healthcare perspective, the growth of teleservices and providing alternatives to accessing healthcare is also something that will probably last, and that's a very good thing because not everybody can get to the hospital, has transportation, and especially for patients with neurological problems where it's really a challenge to come into the hospital, and it poses some risk to be around other patients who may be sick. The ability to now deliver care through video conferencing, I think, is a big step forward. We should have been there before, but COVID definitely pushed us to get it into place quickly.
Yeah, there was actually, Karen, an earlier question about tele-neurology, and how, so you've just kind of answered that, which you've said that some of that is here to stay and for good reason.
Yeah.
Are you set up technology-wise to do this?
You'd be amazed at how quickly, patients already had smartphones and were already using audio visuals for communicating for social reasons. And so we had to make a big push to get everybody the right hardware and to keep things encrypted for privacy. But I really do hope that it remains an alternative and that it becomes, that we have a hybrid healthcare system where the patients who need to be seen come in, but patients who can get care at home find that to remain an option.
And then there's one last little piece, which you and I spoke about last week, and I just think it's really fascinating. And then I'm going to wrap up, but the idea of disease surveillance as well in the community. You remarked on that, Brown, for those of us who are in the Brown community, and welcome to everybody who's listening. But it's been remarkable. If you're in the lab, you can be tested twice a week, and that it's just a phenomenal service and operation. How what are you thinking, the future is going to look like in terms of disease surveillance in community and, preparation for other outbreaks at some point. Yeah.
I hope it's going to be increased. I've done work with Fogarty, which is the International Institute of NIH. And I think over the last decade, in general, I think there's been less effort and fewer resources put into international surveillance, and generally from a sense that we didn't need to do that. And I can't imagine that we can still fall back and feel comfortable that we didn't need to know what was happening in China in December of 2019, and what's happening in South Africa with emergence of these new variants. And so, as a healthcare provider, it really tells me that it's critical to know what's going on globally, because what's across the globe today is going to be on your doorstep tomorrow. And we really need to prepare and have tests available and have accurate tests available, and be ready to deploy them through an effective public health system. So, it's been many, many decades since the US has faced something like this. It's probably, it's something back when polio was around, or, with previous pandemics, people were alert to this. And then we've had decades of complacency, but no longer.
I love that, that you ended on the global theme, kind of where you started, I think. But it's just, I think that this speaks to, I know it speaks to Chris and I, and everyone in, the community. It is a global community, and information is moving quickly, and disease quickly, but you have to be open and you have to look out. And the last thing we want to do is to start to become a closed, isolated community. And so I'm really looking forward to the future of the globalness of science and so yes, important. Now, Karen, actually, I promised you that was the last question, but I actually have one more. Since you're an English literature fan, have you had any time to read? Do you have a book open right now? Do you want to tell us what you're reading? I didn't prep you on this question.
No, I read mysteries, and so
so do I.
The last there's an author, Louise Penny, who writes mysteries with a Canadian detective, and I have to say that was the last book I read and really enjoyed. Ooh. But I scour the book lists looking for new mysteries.
Mm-hmm. So yeah, so I do the same. There's a lot of great Edinburgh authors who are great mystery writers. Yeah. So we should share our list sometime. Thank you. All right. Well, that was, fabulous. I hope you enjoyed it. Thank you for the questions that came in. Thank you, Karen.
No, thank you for
tremendous.
Thank you very much. It's been fun.
Thank you, Chris. I'm just going to wrap up here and just give a quick announcement about the next Carney conversation, which is already scheduled and is going to be held on March the 23rd from 3 to 4 p.m. So join us for that. And we're going to feature a couple of other Brown alum, Josh Cohen and Justin Klee, and they're the founders of a company called Amylyx. And it's a Cambridge-based pharmaceutical company dedicated to the development of therapeutics for the treatment of neurodegenerative disorders. And, I think this will be a really fabulous kind of dovetailing Carney conversation, having heard from Karen, who's in the clinic, day in and day out. We touched a little on neurodegenerative disorders, but then how do you take ideas and get those into development of drugs that, and so they're going to be talking about their path from Brown undergrad to starting founders of a great company that has drugs that have been that are now FDA approved. So thank you all for joining us. Again, thank you, Karen. It was tremendous. Tune in for next time.